We're going to go ahead and get started. If people want to grab a last-minute cookie
I didn't
and
know you were a Michigan.
run to a seat.
Yeah, me too.
Welcome, everyone, to this forum from the National Academy of Social Insurance on tying it all together, long-term care in an era of health reform. My name is Larry Atkins, and I'm the president of the National Academy of Social Insurance. And
for our long-term care commission.
before I get started, I think what I should do is mention a few housekeeping details that I've been told I have to mention or I won't get paid for this. So, one is that you have a purple evaluation form, and you should fill it out and turn it in, or somebody will ask you to turn your cookie back. And then everyone afterwards, after this is all over, and I think that's around 4 o'clock, please leave this is called the ballroom. If you can leave it quickly, so that we can reset it for the Robert M. Ball Awards reception, so that they need to get in and do all their stuff. And then if you're staying for the reception, you'll need to check in again at the registration table. So you can use the hour and a half that you'll have to go do that. And pick up your name badge. There'll be a name badge for that one. And then if you haven't registered, you can register here. And when this is over, you can go register. And that will start at 5 o'clock. So this is a very timely set of panels that we have today here. Timely for a couple of reasons. One is that it's been a very long time since, absent the activity around the Class Act, there was any real serious attention at a legislative level to the need for a lot of additional activity in the long-term services and supports area. And a lot has changed since the last big commission took this thing on, which was the Pepper Commission in the 1990s. And the landscape is quite different today. And as many of you know, what makes this discussion today, I think, particularly auspicious is that on Thursday, the Commission on Long-Term Care that was established by the fiscal cliff legislation at the time that they repealed the Class Act, that commission of 15 members will have its first meeting Thursday, and as part of that, a public hearing starting at 2 o'clock in the Rayburn building, Rayburn 2322. And I know all of this because I am the newly, I'm trying to think of a good word, selected staff director for the Long-Term Care Commission. So I'm honored and a little frightened. But anyway, so it's going to be, actually I think it's going to be a very interesting opportunity to put some really good stuff together. We have a fantastic commission, a lot of expertise resident in the commission, and a lot of diversity of viewpoints, both political and from people's backgrounds. And it'll give us a chance to hear from a lot of stakeholders and really try to get a sense of where things are and how we can move forward. So I'm hopeful that our 3 months between now and September 30th will be extremely productive. But I think before that happens, I think it's going to be very interesting today for you to have a chance to get a sense of how things have changed since the Pepper Commission, what's really going on out there, and partly in relationship to the enactment of the Affordable Care Act, which has a lot of health delivery system changes involved in it and will have an impact on long-term care services and supports, and also the activities that are going on at the state level in trying to come up with new ideas and new approaches. And so I think this is going to be a particularly interesting session today. You'll have an opportunity to hear all of that and engage in dialogue with our panels. And so before I step down, I also want to mention that Lee Goldberg and I drafted a paper on the social insurance landscape in long-term care services and supports and what the possibilities are for the future going forward there. As a thought piece, it was part of a series of thought pieces that were commissioned by the SCAN Foundation, and you'll find a fact sheet on that in your folders. So enjoy and participate, and I will turn it over to Ann. Thank you very much.
Well, thank you so much for being here. I'm Ann Montgomery, and I'm very pleased to be moderating today. Both the first and the second panel, Larry Polivka got stuck in Florida thanks to Delta, which is unfortunate, but anyway. I wear two hats at this point, one at the National Academy, the other at the Alterum Institute, and I've spent a good deal of my career in public service, including a recent stint at the Senate Aging Committee, and I think it's really fitting and wonderful that Larry Atkins is going to be the new staff director, also an alum of the Senate Aging Committee for the Long-Term Care Commission. I think that bodes well. So we're here today really to tee up another national conversation on long-term care, which in some ways remains the great unsolved mystery, the unwritten chapter of our healthcare system. Some have even called it the elephant in the room that no one wants to talk about. But we're here today to do exactly that. And I think that there's a lot of talent in this room and elsewhere, and together I think that we can make a lot of progress. So today, what we hope to do is establish a baseline of where we are on our journey to create a better functioning system for the millions of Americans and their families who aspire to live long, productive lives with access to common sense supportive services that allow them to remain wholly or mainly independent right up until the very end of their lives. And I think it's noteworthy that the two parts of the federal government that are playing key roles in sponsoring initiatives that aim to stretch the capacity of our healthcare system while building better bridges to our system of social services and supports are recent arrivals on the federal scene. And that would be the Federal Coordinated Healthcare Office, or the Office of the Duals, as we usually refer to it. It was created by the Affordable Care Act in 2010. And then there's the Administration for Community Living that was established in 2012 as an amalgam, if you will, of the Administration on Aging, the HHS Office of Disability, and the Agency for Intellectual and Developmental Disabilities. Both the Office of the Duals and ACL are essential components of an evolving strategy to stretch and expand the capacity of the healthcare system, along with our community and social services system, to be able to serve tens of millions more Americans who will need some form of long-term care during the decades, particularly during the decades 2020 to 2050. So in that regard, we're extremely pleased to have James Toews and Banach here for the first panel to talk about their current work. And we also hope to stretch their personal capacity a little bit and ask them to do some projecting into the future. We're equally delighted to have two stellar Senate staffers, Sophie Kasimow from Senator Sanders' Primary Care and Aging Subcommittee, and Ahaviah Glaser of Senator Rockefeller's office, to provide a perspective on what they are focusing on in the legislative arena in the 113th Congress. Collectively, we have a big challenge in front of us, but it's not insurmountable. The Congressional Budget Office projects that Medicare spending will be at about 3% of GDP until 2019, increasing to 3.5% by 2023. It's right around then that things start to get really interesting, with program enrollment projected to increase to 80 million by 2030, an increase of 60% compared to today's 52 million beneficiaries. Also during this period, we'll see a more or less permanent shift to a society that will have relatively fewer workers to support relatively greater numbers of Medicare enrollees. And it's interesting that this phenomenon is also true of many other countries around the globe. With regard to the picture for Medicaid and long-term care, one of our panelists later this afternoon, Josh Weiner of RTI International, said in a recent presentation that long-term care expenditures would increase in the US from about 1% of GDP to between 2.5 and 3% of GDP over the period 2005 to 2050. Given the unprecedented nature of the baby boomer age wave, including a projected quadrupling of frail elders over the age of 85, that the outlook for long-term care spending doesn't sound completely unreasonable. Yet there are ever-present and very real concerns about the excess cost growth trend in average healthcare costs, which, as we know, have dominated policy discussions for the last 2 decades or longer. Speaking of costs, I wonder how many of you are familiar with Stephen Brill's mind-bending account of healthcare costs that ran in Time Magazine's March 4th issue. If you haven't read it, it's a very remarkable piece of work that shows just how far we have to go in order to rationalize our healthcare costs. And we're having an even tougher time talking about revenues. In spite of these large-scale budgetary challenges, we have a serious responsibility to take action to ensure that we don't do misguided things, like make it impossible for frail elders to remain at home by cutting off their access to meals and other basic necessities that make aging with dignity feasible. So it's an interesting time, and as the Congressional Research Service observed in a memo that was written for the Senate Aging Committee earlier this year, quote, there are no simple solutions to address problems raised by the growth in healthcare costs occurring in public and private sectors alike and the aging of the population. No simple answers, but plenty of tough questions, and we will now turn to some of the better minds in Washington, D.C. to provide insight into where we can go from here. And now I'll give some very brief introductions. Full bios are in your packet. James Toews is a senior policy advisor at the Administration for Community Living at the U.S. Department of Health and Human Services. He'll speak first. He'll be followed by Banach, a senior advisor with the CMS Federal Coordinated Healthcare Office, or the Office of the Duals. Ahaviah Glaser is a senior legislative assistant in the Office of Senator Rockefeller of West Virginia. And Sophie Kasimow is staff director of the Primary Health and Aging Subcommittee of the Health, Education, Labor, and Pensions Committee, chaired by Bernie Sanders. Following the panel's remarks, we want all of you, we hope, to step up to the microphone and ask the really tough questions. And with that, I'll turn the podium over to James. Thanks so much.
It's a pleasure to be here. Many, many years ago, Conrad Hilton, the founder of this hotel chain, appeared on the Johnny Carson show. And Johnny said to him, Mr. Hilton, you're enormously wealthy, enormously successful. Why don't you look at the TV camera that there's 9 million Americans watching and just give them some real basic advice. And Conrad Hilton turned to the camera and said, please, please keep the shower curtain inside the tub. So I want to try to lay out a couple very basic points about what I think should happen in long-term care reform as part of this era of overall health reform. I think most of the action in long-term care is going to happen within managed care. Some people disagree with that, but I think managed care is the wave of the future. Capitation models will rapidly replace fee-for-service models in the states. And I think we're going to have to look at both commercial and non-profit plans to do a much better job than states have done in the fee-for-service area. We already know there's many states that have embraced managed care as part of their long-term care strategy. There's probably another 20, 25 states that are actually thinking about doing that within the next couple of years. So I truly think that will be the programmatic design that shapes the future of long-term care reform for better or for worse. And I want to talk a little bit about just what I think programmatically these plans must do if we're going to be successful. I'm not going to talk so much about the financing side, but more about the programmatic side. The first thing that I think we're all looking to plans to do is to rebalance our systems. That's been a topic around for a lot of years. We're terribly unbalanced on the aging and physical disability side. Most of you know the numbers. Nationally, we only spend about 36% of our long-term care expenditures on community-based care, the rest in institutions. When you look at the rates of nursing home utilization from one state to the next, if you look at it per 100,000 of population, it's from a low of 84 to a high of 838. Huge variability in the performance of the states. And I think plans have an opportunity to do where states have failed in their fee-for-service models, because finally under a capitation model, all the fiscal incentives are aligned in the right place under a global budget. And even plans going into states that are terribly unbalanced now, don't have a community infrastructure, can do some things that are already proven without doing a lot of brick and mortar, building of assisted living, foster care, and all that. If you look at a couple models that have been well developed in multiple states, we've been, for example, studying in depth Minnesota's nursing home diversion program. It's almost, I wouldn't call it evidence-based, but it is so systematic in terms of identifying those 25% of post-acute stays that will end up being at risk of long stays, doing a targeted intervention, generating MDS data with an algorithm that actually shows which people should be targeted, assigning those to workers who then go out and prepare plans to help them reintegrate into the community. They're doing extensive reviews now of potential Medicaid and Medicare savings. They have all the protocols designed in terms of the post-placement follow-up. I mean, those are the kinds of things that plans could take almost off the shelf as a proven methodology and begin to implement in states that don't have a very high community infrastructure. Secondly, if you look at states that have done a lot of participant direction, and there's a handful of states, particularly on the West Coast, that provide a tremendous amount of their long-term care supports with participant direction, consumer directed, where people can hire and fire their own family members and friends and neighbors. In Oregon, for example, we had as many people in community-based care under participant direction as we had in nursing homes at the very, very highest acuity levels. We averaged between 200 and 250 hours of paid care per month. But I think, again, that shows that we can implement stuff, and various states that have done these models have all the backup systems, the payroll systems, the electronic timekeeping things in place, that technology, that service methodology could be incorporated very, very quickly by a plan that is serious about rebalancing our system. The second thing, there's been a lot of stuff in the news the last couple days from the Pew Research folks in terms of family caregiving. AARP has done a lot of work on family caregiving. Families are still the long-term care system in this country. 85% of all ADL support, IADL support, is given by family members. There's 40 million Americans involved at any given time in caregiving. We have 15 million family caregivers supporting people with dementia or Alzheimer's. It's an extraordinary figure. I was simply stunned by the report that was released recently by the United Hospital Fund, and if you haven't read it, you should. It's an extensive survey of caregivers that finds nearly half are doing significant medical and nursing tasks, open wound care, tube feedings, running all kinds of monitor system, managing multiple medication regimes, and most of them report they get little to no support from the health community. They leave hospital discharge rooms with bags of equipment, 5 minutes of instructions, and go home and try to manage this on their own. That is absolutely a travesty, and in some respect, I think it almost equivocates to medical malpractice. I think we need to incentivize plans to support family caregivers. The United Hospital Fund has also released a 10-point action plan on what we should do in terms of supporting caregivers to make them an integral part of the health team or the medical home, because they can carry those health extension tasks right into the home of the person and provide them training and support and technical assistance and home visits. And I think we need to incentivize plans to do that, to shore up that part of our long-term care system. Finally, I think we need to see, and I think there are emerging examples, but we need to see real models of integrated care in terms of a person-centered plan. I've read virtually all the proposals coming from the states, whether they're duals demos or 1115 plans or others. And when the health home, the medical home, that thing is described, it's often seems like boilerplate language. And you just sort of search, you'll look for where's the connection with long-term care. What does that integrated plan really look like? Where's the role of the family caregiver or the direct care staff in that person's life as an integral part of that health team? And it just seems to be missing. And I think we really need to look at models that will take that to scale. Because when you think about it, if you're a managed care company and you're operating both acute and long-term care, you have an enormous opportunity. You have a paid presence in a person's home, in their refrigerators, in their kitchens, in their bedrooms, where if you use the care provider, the direct care staff, the home care worker as a member of that health team with very assigned tasks, trained to help that person do healthy living practices, that's how you manage chronic diseases, not in the doctor's office, not in periodic hospital visits. And we have a tremendous opportunity to do that. And I think we need to look at models that will do that. Thank you.
Well, good afternoon, everyone. I'm Banach from the Medicare Medicaid Coordination Office. First, I wanted to thank the organization for having me and my fellow panelists here. I want to keep it short. I want to hear from all of you and hopefully answer some questions later. I want to echo much of what James said, and we've been working really closely with ACL to make sure that we're thinking similar things and that we're saying similar things are informed by each other. First of all, the Medicare Medicaid Coordination Office, as Ann mentioned, was created in the Affordable Care Act. But I want to sort of back up from that. Why was it created? It was created, as you all know, because we've, since 1965, had two programs, Medicare and Medicaid, that never really worked well together. Weren't designed to work well together, and whatever else I say, today, and I'll talk about demonstrations and other things later. Our main challenge is to make the two programs work better together. Given that the population is aging and given that we have fewer resources to work with, we don't have the luxury, and I would argue we've never had the luxury, to have these two programs work at cross purposes, and I'll give some examples. So number one, we're working on Medicare and Medicaid, speaking a similar language, working together, cutting down on sort of the administrative back and forth, and that's most important. We don't need the Medicare and Medicaid gaps to be an impediment to people living a healthy life in the community. If Medicare and Medicaid treat DME or home health differently, for example, and that leads to someone being institutionalized just because Medicare and Medicaid were fighting, that's a travesty. And so that's what we're trying to fix. Congress laid out some very specific goals for our office, talking about access, quality, simplification of the processes, increasing understanding, eliminating regulatory conflicts, and a lot of things that we've been doing since being established are in that spirit. Okay, so clearly cost is an issue, and clearly we want to address that. But the way to address that, we feel, is by building a better system. Get Medicare and Medicaid to work better together. Address some of the cost sharing and some of the sort of the coverage issues, some of which I spoke about, and then really put the beneficiary at the center of this system that we're building and ask whether it's a system that's going to enable us to meet those goals. That's our challenge. The other thing I'd mention is, again, clearly, we're going to be, as a nation, I think, relying more on plans to deliver Medicare and to deliver Medicaid care. That doesn't mean a few things. One, it doesn't mean that the current network that provides long-term services and supports is irrelevant or is not a part of that process. It is a crucial part of that process, and there's a good way for plans, I think, to grow and to stretch to meet the need, and there's a bad way for them to grow and to stretch and meet the need. Okay, and one example from my own life is when my wife was pregnant with our first child. I remember it was a fine pregnancy. He's 4.5 and doing well. Got a call from some care coordinator in Alabama, and she said, some medical talk, and she asked how things are going, and our reaction was basically, this is creepy. We don't know you. How do you know this about us? We're not talking to you at all. But some plan had paid some company a lot of money for that company to call us up and coordinate our care. That's not a good way of doing it. It's not effective. It didn't utilize anybody we knew or anyone that sort of spoke with our accent even. And that's important. I think realistically, as James said, I think we do have to rely on the networks, and really we need to rely on the caregivers of the individuals to help with some of this work. Not only because it's the right thing to do, but also because it happens to be more effective. A little bit about the demo, because I think that's gotten a lot of attention, and we do have demos that our office is working on, 5 capitated model demonstrations, 1 managed fee-for-service demonstration. I want to stress that this isn't the only stuff that we're doing in states or the only thing that we're doing with these states, but we do believe that it's a good opportunity, these demonstrations, to sort of marry together the Medicaid authority that already exists with new Medicare authority that the Innovation Center has to waive all of Title 18, which is all of Medicare. Not to dilute or to make it more difficult to get access to services, but really to build on the services that people have. And again, I'll give you another example. For Medicare, getting non-medical services, and I just got just had this conversation recently. For Medicare, a gym membership, for example, that's meant to get someone healthier, or sometimes non-emergency transportation, or sometimes home-delivered meals, are viewed as sort of non-medical and therefore a reason not to provide these benefits. Now, plans have this flexibility, more plans have this flexibility. But the flip side is true under the demo, and really the flip side should be true for if you're looking at the entire person. We want people to be healthier. We want people to get home delivered meals. We want people to get pest control. And we want plans to be able, within their capitation, to pay for those services. That's going to keep people at home, and that's a good thing. So more and more, I think we're trying to bring together, and it's hard work, the long-term services and supports that are on the Medicaid side and the Medicare benefits into a unified benefit with unified rules that are going to cut down on the administrative back and forth, but create a system that's more easily understandable and navigable for beneficiaries. We want to provide support for the options counselors on the front end and assistance on the back end once individuals are enrolled to help people navigate these new systems. Anything that's new is new, and people are going to need help navigating them. People are going to need help making choices, and it's our interest to make sure that they make the choices that are best for them. So, what I want to end with is, where does the Aging Services Network come into these demonstrations or come into our work? And I would say in spades. Without the network, without this network or the network that serves younger individuals with disabilities, these initiatives, most of our initiatives that we're working on, literally cannot work because of what I said before. That unless you leverage the networks that have been providing these services, you're going to do it in a suboptimal way. The flip side is what it means for these networks is, to work together, less territoriality, and more coordination amongst each other, but also with the managed care companies and the health homes and the medical homes that are providing these services. It's a two-way street. Real opportunity for the networks and also real opportunity for the health plans and providers that are undertaking this work to really do this right. And with that, I want to stop and happy to take any questions after. Thank you. Thank you.
I'm actually, for those of you who know me, I tend to be fairly casual, so I think Sophie and I are going to stay seated in anticipation.
I didn't know that was an option.
I wrote you a note. You didn't read the note. So we're gonna stay put for those purposes. Obviously, the issue of long-term care and long-term services and supports is really of singular concern to my boss, Senator Rockefeller. He was very involved in the Pepper Commission, and I think as he looks at the end of his time in Congress, he sort of sees long-term care as the one field where really nothing has been done. He's been here for years. He's made tremendous strides in so many areas, particularly children's health and some other things, but really at the end of the day, what is new in long-term care from so many years ago? The answer is not a whole lot. So, I mean, with that in mind, actually, I'm really proud to be working for someone who helped author the provision in ACA that created the Duals Office, and also authored the provision that created the Commission on Long-Term Care. And so our office is doing an awful lot of thinking in this area. With respect to the Commission, which, as you heard Larry say, and we're delighted that Larry is at the helm, that, the Commission, we're hoping, can do a combination of things. One is to sort of really think through what is the vision for the future, with a clear understanding that it won't be a single vision, but that there are probably a variety of options that need to be explored. It's also very much the wish of our office that there be some more immediate solutions looked to so that come the fall we can introduce some legislation coming out of the Commission's work. I had the pleasure of speaking with all of the nominated commissioners, and it seems to me that there's certainly room in the space that James talked about and Ido alluded to around making it easier for people with disabilities to get the supports they need that enable them to work or get further education, things along those lines. And there was not a single commissioner that we talked to that thought that long-term care private insurance was a fully functioning market. So I think that there's a lot to be done to put consumer protections in place within that market and also sort of create products that are better understood. I mean, ultimately,